So good morning again. I'm not going to tell great news. I will leave that to Ashish, but I would give some important just starting points on bladder cancer for certainly some people in the room that are not so familiar with it. If we talk colon cancer, patients are often sent home after a colonoscopy and they say, yes, you have 2 or 3 polyps. We have removed them, and that's it. That can happen with bladder cancer as well. There is no benign polyps in the bladder. There are some. It's inflammatory polyps. But if you see a tumor, a polyp in the bladder, it's a transitional cell carcinoma or another type. So looking at bladder cancer, since the majority is non-muscle invasive, is 80%, and only 20% is muscle-invasive bladder cancer, this gives not the bad name to bladder cancer, what it actually deserves. For me, bladder cancer is as bad as lung cancer and as pancreatic cancer, that we know that is killing a lot of people. It's not the non-invasive muscular bladder cancer that is killing the people. So there's an important knowledge that people should have. If you have a polyp in your bladder, go back because you need check examinations every 3 months, a cystoscopy, and so on. The median age when we are contacting bladder cancer in Western Europe is 65 years. And it has been said it's the 5th in Europe. Worldwide, it's the 9th most common cancer, and it's the 13th killer. Will it kill more if we do not do something about tobacco abuse and about carcinogens in the industry? It will kill more. Prostate cancer is going to kill more than before. Why? Because men are growing older. And the older you get, the higher likelihood you have to get prostate cancer. So this is the most recent data from IARC that we can rely upon. And obviously, that's the big thing. Not all bladder cancers are caused by smoking or by industry. And it has been said this morning very correctly. But the important thing to see is where there's a lot of smoking, like in Lebanon, in Greece, there is an enormous amount of bladder cancers. And then you see the death rates in the red bars. And that's very different. There's countries where about half of them die from bladder cancer once they have it. And this has certainly to do with the follow-up and the treatments that patients can get. Next to smoking and tobacco, there is post-radiation exposure. It's not that common any longer, but many years ago, many people got radiation to the pelvis for one or another reason. Even for prostate cancer, after radiation, you can have a higher likelihood to develop bladder cancer. Chronic bladder inflammation, and the best examples I knew and I saw were patients with neurogenic bladders, multiple sclerosis patients, that wear catheters for years, and that then in the end develop bladder cancer. And then the exposure to chemicals, the rubber industry, the metal industry, and so on. And then this is all mostly transitional cell carcinoma, that's what we call it. On the other side, there's the parasitic, the schistosomiasis, which we see in Africa, and it's a different type. So TCC, as you see below, is transitional cell carcinoma. That's the most common in the developed countries, while squamous cell carcinoma that emerges from the eggs of this schistosoma, this parasite, in bladders in the Middle East, in Egypt very frequently, where they have the highest expertise in bladder cancer treatments, surgical treatments, because they see them so often. Now, the treatment choices are different, and Ashish will certainly come back on that. At my time, we had TOR of the bladder and epirubicin or mitomycin C bladder instillations for non-muscle invasive bladder cancer. More recently, and for you that's not new at all, there was BCG. What do these agents do? They irritate the bladder wall they give severe cystitis. Actually, the patients are voiding their epithelium, and we make a new epithelium that we then hope is healthy again. With BCG, we have added immune therapy, so that there's an immune response that must preserve the patient from developing a malignant recurrence. For muscle-invasive bladder cancer, it's more complicated. It's also very much different from the place where you live. When you live in the UK, the likelihood that you are getting a cystectomy is much lower than when you live in any other country, be it in France or in Italy. And I remember that I did surgery in Malta. The Maltese doctors were trained in the UK, and in the UK there were much less radical prostatectomies and much less bladder cancer surgeries, simply because they did for bladder cancer the triple therapy, which is transurethral resection, maximum debulking of the tumor, chemotherapy, and radiotherapy in order to preserve the bladder, which was not popular on the continent where we did more cystectomies. And we were, so to speak, more allowed to do cystectomies because we were able not to offer breaker diversions, cutaneous diversions, which are highly unpleasant for patients, but we were able to do bladder replacements, bladder substitutions. Bladder substitutions have the big advantage that you void through your normal urethra. They have the disadvantage that they can be complicated by either urinary incontinence and, in many women, hypercontinence. So they cannot urinate and they have to self-catheterize themselves. Other solutions are cutaneous diversions and continent cutaneous diversions, which is the most difficult. And you will understand that with the minimal invasive surgeries today, with the robot surgery, what the surgeon prefers in order not to operate 6 or 8 hours, they will do the most easy diversion. This means a cystectomy and an ileal loop diversion with a stoma. And this is a bit funny for me, because if we look at the quality of life of a man with a replacement bladder and the man with a stoma, that's completely different. Now, there is neoadjuvant and adjuvant therapies for muscle-invasive bladder cancer that we know now very well. You do not do a T3 bladder cancer cystectomy without the patient having had neoadjuvant chemo. There is indications for adjuvant chemotherapy. This is conventional chemotherapy. And then there is the upcoming for advanced bladder cancer, next to the conventional chemo, the immunotherapy, the checkpoint inhibitors, PD-1, PD-L1, and the monoclonal antibody therapy. And I leave this up to Ashish to come back on that later. You are probably all familiar with these possible diversions. On the left, there's the stoma. That's the wet conduit. That's the wet stoma. In the middle, there's the continent stoma with a pouch, as you can see, which is the most complex to perform. It's also the most complicated, has the most complications. And then there's the bladder replacement, as I said, an ideal in men, a bit less ideal in women. So this, in the end, means that there will always be more women with stoma than men, which is a gender difference that I believe can only be solved by centralizing bladder cancer care and surgery so that people can have the best possible complicated, complex surgeries in the best possible way. Influence of surgical volume and hospitals, I do not have to repeat. I think we need to centralize care. Not every urologist should take care of bladder cancer once it becomes muscle invasive. I believe, on the other hand, that non-muscle invasive bladder cancer should be done by the regular urologist because they are trained and able to cope with it. So we can do better than what we have been doing up to date. Primary prevention, tobacco and chemicals, and this awareness, and make bladder cancer patients working in the rubber industry for their entire life, make them recognized as a professional cancer, for which special reimbursement must be foreseen. Secondary prevention is one of my hot topics in prostate, as you know. It's screening, actually. Whom should we screen? People at risk. It's like in lung cancer. Smokers get a CT scan. Non-smokers do not get a CT scan, although they develop lung cancer as well. Is this unfair to better treat people that do not behave as they should? So that's a question that we need to explore. Can we do anything else than a cystoscopy to diagnose a bladder cancer? Yes, we can. The studies have been done by Florence Calvé-Kelm from IARC. They have been looking in different parts of the world, and there is a urinary marker, third promoter mutations, that can be detected, and that can indicate that someone will develop in 5, 6, or 7 years from now a bladder cancer that is not visible yet. You immediately understand that this also brings problems. How are you going to follow these people? You will develop cancer in 5 years from now, but maybe tomorrow. How often are you going to repeat the endoscopies to find finally the cancer? But there's certainly a way to go forward. It's not very expensive. It could be available for 25 euros, and it's a test that could be done in risk populations or people that are afraid for getting bladder cancer. Then, hematuria, algeria frequency should be taken seriously. That's awareness. And women with recurrent urinary tract infections, women with hematuria, women with vaginal discharge should not be looked at infectious diseases. They should be looked for and having a cystoscopy anyway. Now, we need to have better access to early diagnosis and modern treatments, minimal invasive techniques. When I did a cystectomy 20 years ago, patients were in the hospital for 2 to 3 weeks. Now they're in the hospital for 48 hours. With minimal invasive techniques, this is really a major, major advancement. Bladder sparing and bladder replacement strategies targeted and immuno-oncological treatment must be available, and patients shouldn't go to centers where they cannot have it. So the question is, what do you do about the East and some countries in the South? Centralization of care in specialized centers with multidisciplinary teams, multidisciplinary consultations must be imposed. A urologist on his own around the corner cannot treat a muscle-invasive bladder cancer. He must work with multidisciplinary teams. Facilitate and stimulate access to clinical trials that had been said before, and then address the research funding and the cancer mission, Beat Cancer Plan, the multi-annual financial framework. This is where we have to work to get more funding for what we all aim at, a better fate for our bladder cancer patients. Thank you so much.
Hello, everybody, and greetings from Houston, Texas. I really wish I could have been there in person for this very important meeting, so I want to thank the organizers for the opportunity to present this virtually instead. You know, when Alex and the organizers asked me to present on what I think is the current state of the art and most important research advances, there was really so much that you could choose from when it comes to bladder cancer. There's the advances in non-muscle invasive bladder cancer with new treatments and drugs in the BCG unresponsive space. There's the use of machine learning and AI when it comes to diagnosis. There's new urinary markers. But I really think that the one field and the one paradigm shift that we all need to be aware of is in the management of patients with muscle-invasive bladder cancer. And I'm going to focus on that for today's short presentation. So we all know the global burden of bladder cancer. There's roughly about 614,000 cases per year. This is 2022 data. It appears to have gone up slightly this year, and about 220,000 deaths globally. If you look at the global incidence, it's the 9th most diagnosed bladder cancer. Of course, the incidence is higher in certain parts. For example, in North America, it's the 4th most common cancer amongst men. And in most cases or most countries, it is between the 10th and the 13th leading cause of death. Now, like I said, There have been a lot of advances in bladder cancer in general, but for today's talk, I'm going to focus on the patients with muscle-invasive bladder cancer. These are those that have tumors that have invaded into the muscularis propria or into the surrounding tissue of the bladder. So what's the current state of patients with muscle-invasive bladder cancer? We know that muscle-invasive bladder cancer has a high risk of recurrence and death despite chemotherapy and surgery. The desired state would be to improve survival in muscle-invasive bladder cancer patients with personalized treatments, and of course, reduce the need for bladder removal. And how can we achieve this? Well, we can achieve this by essentially addressing the gap. Innovation in trial design, multidisciplinary care, and to harmonize eligibility, imaging, and biomarkers. This is where research is, and this is where research is headed. So to summarize, really, the main therapy options for patients with muscle-invasive bladder cancer today are surgery, which includes removal of the bladder or adjacent structures, as well as reconstructive techniques. Radiotherapy, which fortunately is being used appropriately in patients with increasing frequency nowadays, well-selected patients who either are not candidates for bladder removal or have tumors that are specifically amenable to radiotherapy, and of course, chemotherapy. Now, chemotherapy is used currently to improve the results of surgery or radiotherapy, either in the neoadjuvant pre-surgical setting or in the adjuvant post-surgical setting. And the aim of the chemotherapy is to further enhance the clinical benefits of localized therapy. Now, neoadjuvant cisplatin-based chemotherapy prior to radical cystectomy does improve survival in patients with muscle-invasive bladder cancer. This is old data. This is a randomized trial that one of my former colleagues and partners, Bart Grossman, published in 2003. And of course, it was also shown in the EORTC study that was published in 2011. So neoadjuvant cisplatin-based chemotherapy really is standard of care for those patients who can get chemotherapy. But really, 50% of patients who are deemed requiring neoadjuvant chemotherapy are not able to get it. And roughly 30% of patients refuse neoadjuvant chemotherapy because of the toxicity of cisplatin-based chemotherapy. So there's room for improvement, and this is where the current research and paradigms are moving. So for patients who cannot receive neoadjuvant chemotherapy, some are suitable for adjuvant chemotherapy. The advantages of adjuvant chemotherapy is that chemotherapy is administered after accurate pathologic staging. Therefore, treatment in patients at low risk for micrometastatic disease is avoided. And of course, there's no delay in definitive surgical treatment. The disadvantages are that the assessment of the in vivo sensitivity of the tumor is not possible. So what this means is that we will sometimes give chemotherapy and see what is happening to the tumor using imaging, and this allows us to either continue with the same therapy or switch treatment. You clearly can't do that in the adjuvant setting. And of course, there may be delay or intolerability of the chemotherapy because of the patients having had surgery or radiation, and which can cause a decrease in function of the patient. Now, adjuvant therapy, the ultimate goal, of course, is to improve disease-free survival or overall survival. And you can see here that when you look at deferred therapy versus immediate therapy, there is a benefit, but it's not really statistically significant for overall survival. However, progression-free survival is improved. And this is the classical adjuvant chemotherapy, essentially using cisplatin-based chemotherapy. And an ABC meta-analysis did show a 6% absolute improvement in overall survival with adjuvant chemotherapy at 5 years. Now, there has been an explosion of IOs, which is immunotherapy, and this is especially true in the adjuvant field. So there's IMvigor010, which used atezolizumab versus observation after radical cystectomy. This did not meet its primary endpoint of overall survival, disease-free survival, or disease-specific survival. Checkmate 274, essentially nivolumab versus placebo, where the primary endpoint of disease-free survival was met, but overall survival was not statistically significant. In the ambassador study, which was pembrolizumab versus observation, the co-primary endpoint was disease-free survival, overall survival. There was an improvement in disease-free survival, but no improvement in overall survival. This is the data from the Checkmate study. Essentially, this is patients that had high-risk disease, so those that had residual disease after chemotherapy or advanced pathological stage despite chemotherapy and not candidates for chemo. They were then randomized to placebo or nivolumab, and you can clearly see here that patients that got nivolumab had improved disease-free survival. There was a separation of the curves when it comes to overall survival, but this was not statistically significant as of yet. Now, if you look at phase 3 IO studies in muscle-invasive bladder cancer, I mentioned the adjuvant studies. Then, of course, there's cisplatin eligible patients where we're trying to give them something if they can't get cisplatin. And this is essentially the Volga study, the EV303 study, which everybody's talking about, which will be presented in a few weeks with EV Pembro, and of course, more treatment with Nectar as well. And of course, in patients that are cisplatin eligible, what can we do to improve their outcomes? So the Niagara study essentially looked at combining durvalumab with standard chemotherapy. The Energize is Nivo with standard chemotherapy. Keynote 866 is Pembro with standard chemotherapy. And of course, then we have the EV study, which is essentially enfortumab and pembrolizumab and doing away with chemotherapy entirely. So let me talk about Niagara study and how this has actually changed the paradigm for patients. So this, like I said, is patients with cisplatin eligible muscle-invasive bladder cancer, clinical stage T2 or T4A or N0, N1, randomized to either the comparative arm, which is standard cisplatin gemcitabine chemotherapy, or the treatment arm, which is standard plus durvalumab given every 3 weeks into 4 cycles. The patients underwent radical cystectomy, and those that were on the durvalumab arm actually underwent adjuvant therapy for further 8 cycles. If you look at the event-free survival and the overall survival, this was reported as being essentially statistically significant with a hazard ratio of 0.68 for event-free survival and overall survival of 0.75. So essentially, this trial showed for the first time that we can improve on the results of neoadjuvant chemotherapy by using neoadjuvant chemotherapy plus IO therapy. And this is one example of subgroup analyses, and I only show this because a lot of times patients will ask, if I get this treatment and I have a PAT CR, essentially that's what this means, that there is no more tumor present in the bladder at the time that the bladder was taken out, do I still need to get adjuvant therapy? And the answer is, based on the study, yes, although the relative benefit is low. So based on the patient's risk tolerance, risk profile, we may omit adjuvant therapy, even though on the study it was given to everybody. And this is, essentially the paradigm that I'm talking about, the bladder preservation strategies in muscle-invasive bladder cancer that we published as part of the International Bladder Cancer Group retreat recommendations. Many of you here in the audience are present. Of course, the World Bladder Cancer Patient Coalition is an integral part of what we do with the International Bladder Cancer Group. And I want to touch upon a little bit as to where the research is heading. So essentially, one of the things that we proposed is that we should be able to better identify and offer bladder preservation with radical cystectomy to appropriate patients that are candidates for radiation therapy. So you can see here, we divided these into factors that may favor radical cystectomy, factors that may favor trimodal therapy, but it's a continuum. And this is where the research needs to go and research needs to head. Currently, which patients qualify best for trimodal therapy? Unifocal T2 disease, no multifocal CIS, no hydronephrosis, and of course, good bladder function. Very important. But the other ways in which we're moving towards bladder preservation is exemplified in this study by Matt Gelsky. This is where patients got neoadjuvant chemotherapy. This is gemcitabine, cisplatin plus nivolumab. And then they underwent clinical restaging prior to radical cystectomy. So this is after the treatment, before any radical cystectomy. If they had a clinical complete response with cystoscopy, biopsy, negative cytology, negative MRI, they were offered the option of no radical cystectomy versus cystectomy. And if they chose to have no radical cystectomy, they underwent nivolumab for 8 cycles. Now you can see here that in this very selected group of patients, clearly those that have complete clinical response and then get further therapy, the metastasis-free survival was actually pretty good. And it was obviously better than those that had no clinical complete response, with the predictive value of that clinical complete response at 2 years being 0.97. So again, this is something that needs to be studied. It can't be offered as standard of care for patients. And it's a paradigm that we and others have proposed. This is essentially from the manuscript that I showed earlier. Patients should be enrolled in trials, and these are some of the studies that should be ongoing, where patients undergo systemic therapy. Currently, it's neoadjuvant chemotherapy, could be neoadjuvant chemo plus IO, or whatever the current standard of care might be next year. And then patients can be assessed for complete clinical response, negative cytology, negative cystoscopy, negative TRBT, negative imaging. We need to also incorporate the use of markers, ctDNA, genomic markers, etc., and then offer the patient bladder preservation on a clinical trial. So, in conclusion, the perioperative space for muscle-invasive bladder cancer is evolving rapidly. When adjuvant IO is effective in selective patients, the lack of overall survival does need to be considered. ctDNA holds promise in patients' selection for adjuvant IO therapy. I didn't go too much into detail in that because that's going to be presented at the upcoming ESMO meeting, and it's currently still embargoed. Bladder preservation after neoadjuvant therapy needs to be refined, and clinical complete response need to be studied very carefully. So thank you very much for your attention, and best of luck to all of you for a very fruitful rest of the meeting.